We are going to study about peptic ulcers drugs. Okay, today is pharmacology and we are going to study gastrointestinal pharmacology. We are going to study the part where we are going to talk about the classification of drugs used in peptic ulcer. Okay, now what is a peptic ulcer disease? Peptic ulcer disease, as you guys know, it happens when people have a lot of when basically there's an imbalance between the um, destroying elements in the stomach, and the safe elements in the stomach. This is the wrong word to use, but rather I would say the more acidic stuff in the stomach, like pepsin, hydrogen chloride, HCl. Okay, on all the gastric juices, there's a disbalance between the gastric juices and the basic or the protective layer of the stomach, like the mucus, the bicarbonate ions, everything. So when there's a disbalance in it and the gastric juices kind of increase more than the bicarbonate and stuff, then what happens is there's a disintegration of the gastric layer or the mucosa of the stomach, which leads to the gastric ulcer disease, which can also leads to bleeding of the layer and everything. So for this, there are plenty of other things that happen, like GERD, gastroesophageal reflux disease, and everything. So, and acidity and everything, it can also lead to gastric carcinoma and everything. So this is the thing. Now the drugs used to treat peptic ulcer, okay, or disease is drugs used in peptic ulcer disease are, first of all, this is proton pump inhibitor. The first drug used is omeprazole, proton pump inhibitor. All the ones that end with prazole, rabeprazole, omeprazole, lansoprazole, and pantoprazole. Omeprazole is the it's called the I forgot the word. Omeprazole is the prototype drug of PPIs. Okay, now there's another classification called PCAB. Okay, potassium channel acid blocker. Potassium competitive acid blocker. Okay, vonoprazan is the example. Vonoprazan, VONOPRAZAN. And then there is H2 receptor antagonist. H2 receptor, the H plus ions का receptor जो होता है उसको block करने वाला. H2 receptor antagonist example is ranitidine and cimetidine. Okay, these are actually kind of banned. Okay, now famotidine is the most other accepted drug. Okay, famotidine. Okay, antimuscarinic agents are used, such as your perenzypine and telenzypine. Okay, perenzypine and telenzypine, and prostaglandin analogs such as misoprostol. Sorry, again drug name confusion. Misoprostol. Okay, now ulcer protective drugs. I'll come into the details of this later, but ulcer protective drugs mein we have BCBS, colloidal bismuth subcitrate, okay, and a sucralfate. Okay, and then we have drugs that neutralize the gastric acid secretion. One is the non-systemic and other one is the systemic. Okay, non-systemic are magnesium hydroxide, or it is also called milk of magnesia. Okay, and calcium carbonate. Okay, systemic antacids include sodium bicarbonate and sodium citrate. Anti-H. pylori drugs. H. pylori is a bacterial infection, gram-negative bacteria that causes peptic ulcer disease. Amoxicillin, clarithromycin, tetracycline, metronidazole. It's a very important drug. Metronidazole causes a disulfiram kind like reaction. So it is contraindicated with alcohol, because disulfiram like reaction, when you take disulfiram, what happens is your basically you have alcohol, then it converts to aldehyde, and then it gets converted to acetic acid. So alcohol को कन्वर्ट करने के लिए अल्कोहल डिहाइड्रोजनस लगता है. सो डाइसल्फिरम जो होता है वो अल्कोहल डिहाइड्रोजनस को इनहिबिट कर देता है, तो बॉडी में एल्डिहाइड एक्यूमुलेशन हो जाता है. यू कांट कन्वर्ट इट इनटू एसिटिक एसिड, सो इट डजंट गेट एक्सट्रीटेड. एल्डिहाइड फॉर्म में भर जाता है, एंड देयर आर consequences for it in the body. some manifestations. So metronidazole, this anti-H. pylori drugs, is when you're taking, make sure you're not drinking. Obviously, if you're having a stomach issue, you shouldn't drink in the first place, so it goes without saying. Anyways, so talking about proton pump inhibitors, how do they work? Okay, it is basically a membrane bound enzyme, and it is one of the most important and the most one of the best drugs for peptic ulcer disease. So basically what the not pathogen, it's not the mechanism of function of proton pump inhibitor is. Proton pump inhibitor is taken, it gets absorbed into the blood, okay, then it reaches the parietal cells, it diffuses into the parietal cells of the stomach. From there it reaches the canaliculi of the cell, which is acidic in pH. Okay, so there the PPI gets converted to sulfonamide. Sulfonamide is the activated form. This activated form, sulfonamide, binds covalently to the SH group, sulfur hydride group, sulfyl hydride group, okay, which irreversibly inactivates the proton pump. Okay, this is the mechanism of action. Now, this is the thing, and the therapeutic uses of proton pump inhibitor is used in peptic ulcer disease. It is the most powerful acid suppressive agent. Okay, omeprazole and all this are not usually used because they are banned. I'm so sorry. Omeprazole is used. It is a prototype drug, but rabeprazole is really important. So peptic ulcer disease mein you need a 6 to 8 week continuous uses of it every day, one dose, for therapy and healing, and they are better than H2 blockers any day. Okay, then they are also used in acute bleeding ulcers also. Okay, they are preferred in acute bleeding ulcers for suppressing this acid secretion. In H. pylori infection also they are given along with combination of an antimicrobial like amoxicillin or clarithromycin or whatever, and NSAIDs are induced, पेप्टिक अल्सर जो होता है लाइक मे बी एस्पिरिन इंड्यूस्ड NSAID होता है वो. PPIs are more effective than H2 blockers in that case also. Okay, Zollinger-Ellison syndrome में भी वो यूज़ होगा. Okay, and GERD में भी वो यूज़ होता है. It is given once daily. Okay, it heals erosive and esophagitis. That is the things. Okay, therapeutic uses mein you can write all this. It is used in peptic ulcer disease, in acute bleeding ulcers, in Helicobacter pylori infection, in NSAID induced ulcers, in Zollinger-Ellison syndrome. Okay, it is preoperatively given in pneumonia aspiration pneumonia. It is given in GERD problem also. Adverse effects. PPIs are generally well tolerated in our bodies, okay, but overuse can, like for a very long time use, can decrease the B12 absorption. Okay, the basic adverse effect you have to write for all these is headache, diarrhea, vomiting, nausea. Okay, vomiting is not a thing. Headache, diarrhea, nausea, and abdominal pain may be there. That's it. Drug interactions में omeprazole can inhibit in metabolism of drugs like phenytoin and warfarin. PPIs decrease the bioavailability of other things. You don't really need to know all this. Rabeprazole has the least amount of interactions with other drugs, so this is the most safest. H2 receptor antagonist. Okay, H2 receptor antagonist means basically it competitively blocks the H2 receptors present on our parietal cells. Okay, so it inhibits the gastric acid production. They suppresses all the phases of the gastric acid secretion. They are mainly used for nocturnal gastric problems, nocturnal acid secretion. They are administered orally. Examples of mechanism, all this is cimetidine, ranitidine, all that. Cimetidine was a prototype drug and it is not used right now because of its adverse effects. Ranitidine has been banned and it has been removed from national list of essential medicines in India. It is a very it has a potent carcinogen in it. The most accepted drugs are famotidine. Okay, cimetidine is still used, but famotidine is the most accepted drug. Famotidine and nizatidine. okay, famotidine and nizatidine. Therapeutic uses, again, you have to just elaborate on this key. They stop the H2, so stops the gastric blocks the H2 receptors, and then hence stops the gastric acid secretion. The peptic ulcer disease may you will give it in GERD, you will give it in NSAID induced ulcers, you will give it in stress ulcers, you will give it in Zollinger-Ellison syndrome, okay. And it can also be used preoperatively in aspiration pneumonia again. Now there's comparison you should know between cimetidine and ranitidine. Okay, both are H2 blockers, both are competitive blockers. Okay, cimetidine is less potent, ranitidine is very potent. Okay, cimetidine has a shorter duration, maybe 6 to 8 hours. Ranitidine, has a longer duration for like 24 hours. The increased cimetidine, when you use it, it increases plasma prolactin level, and it kind of causes menstrual irregularity in women, and gynecomastia and impotency in men. But ranitidine has no such anti-androgenic effect. Okay, it does not causes prolactin secretion. Cimetidine can cross blood-brain barrier and can cause CNS effects such as confusion and headache, hallucination. Ranitidine can't cross blood-brain barrier, has poor thing, and so no CNS effects are seen. Simple as that, all is done. Anticholinergic drugs may we have perinzepine and telenzapine. Okay, pyrinzapine, PIRENZEPIN. Perinzapine, telenzapine, they are M1 receptor blockers. They have anticholinergic effects. Okay, so they have, and also they have low efficacy, so they are not really that good. Prostaglandin analogs are used. Misoprostol, okay, is one of the misoprostol is a good drug. It is a prostaglandin analog. Okay, it orally prevents NSAID induced gastric and duodenal ulcers. Okay, PG, like prostaglandins inhibit the gastric acid secretion and increases the mucus and bicarbonate secretion. Okay, this is the mechanism of action kind of. Misoprostol is kind of contraindicated in pregnant women because it may cause uterine contractions. Now we are going for the this was the drugs for these were all these kind of drugs, all these so-called drugs of the peptic ulcer disease were what kind of drugs? They were all they were all proton pump not totally proton pump inhibitors. They were all these drugs inhibit the gastric acid secretion. Proton pump inhibitors, H2 receptor antagonist, okay, anticholinergic drugs, and prostaglandin analogs, they reduce the gastric acid secretion. Now ulcer protectors, okay, sucralfate, what do they do? Now these kind of drugs, it is a complex of aluminum hydroxide and sulfated sucrose. Okay, now the kind of work is they don't actually stop the gastric acid secretion, but rather what they do is they work in this way. It also they precipitate the proteins, okay, at the ulcer base and forms a barrier against the acid, that is the pepsin in our stomach. Okay, so they are indirectly stopping the ulcer thing. Okay, also they go to the ulcer base and they make a coating so the pepsin doesn't enter and hit it. It also increases mucus and bicarbonate secretion. Okay, and it stimulates the prostaglandin so that epidermal growth factor can increase in that region of the ulcer so that it heals. Okay, so they kind of decrease the absorption of many drugs like you can say digoxin and everything. Okay, after introduction of PPIs, another side effect is constipation is a common side effect of sucralfate. Introduction of PPIs, sucralfate is seldom. Okay, so it is actually sucralfate is very effective in stopping the bleeding, okay, from stress ulcers and anything. It is also used in GERD, okay, for stopping esophagitis. Colloidal bismuth subcitrate, again another kind of ulcer protective drug. It has one of the most components, like it is used in H. pylori infection. Okay, precipitates proteins and protects the ulcer base. This mechanism is same for all ulcer protective drugs. Okay, again mucus and bicarbonate secretion will be increased. One of the side effects is the blackening of tongue and stools, which patients don't like, so they kind of avoid this. Drugs that neutralize the gastric acid. We see the drugs that protect from the protective ulcer protective drugs. Now we are going to study about drugs that neutralize the gastric acid, say like antacids. Okay, now we'll talk about the antacids. Antacids, as I said, they are weak bases that neutralize the gastric acid and raises the gastric pH. It makes it more basic in our stomach. Okay, now there are types of antacids: non-systemic and systemic. I said already. Non-systemic, may you have milk of magnesium and magnesium trisilicate, calcium carbonate. Calcium carbonate is very important, you have to remember. Non-systemic. But systemic में you have sodium bicarbonate, okay, and sodium citrate. So non-systemic में क्या होता है कि you give all this, okay, and the main thing is when these drugs reaches the intestine, okay, they kind of increase the weak bases in your stomach. So what happens is it kind of neutralizes the acid secretions, right? Like systemic antacids में बोला जाए तो sodium bicarbonate neutralizes the gastric acid. Okay, it is highly water soluble, so it is really rapidly absorbed from the gut. It releases CO2 that can cause a little bit of problem in your stomach, like it can cause some abdominal distension and bulging. It can cause metabolic alkalosis. You can become very alkaline in your stomach, and maybe it can cause a little bit of rebound acidity, because since you're alkaline, your stomach will produce more. It's bound to produce more acid now. Okay, now these are actually present as suspensions, tablets and powders. You don't really need to know the drug interactions with this antacids. Now we'll go for the potassium competitive acid blockers. Okay, this is also a kind of drug that stops that kind of tries to neutralize it. Okay, the gastric acids. Vonoprazan is a PCAB, and it can be taken orally at any time of the day. They provide long-lasting acid suppression. Okay, now the mechanism action is it gets PCAB is taken. It's a weak base. It's absorbed in the blood. It diffuses into the parietal cells, canaliculi of the cell. Okay, now it compete with the potassium and bind to the H plus. It competes with the potassium and binds to the hydrogen and potassium ATPase. Okay, it binds to the hydrogen potassium ATPase at the potassium binding site. It prevents exchange of potassium with hydrogen. So what happens is it becomes reversibly and competitively blocks the proton pump. Basically potassium कम है, okay, potassium तो भर भर के नहीं आएगा ना पेट में. So what happens is you take this and it reversibly competes with potassium hydrogen ATPase and blocks it from reversibly and completely blocks the proton pumps. They kind of block the proton pump and prolonged inhibition of acid secretion, so you don't secrete acid. This is also a kind of antacid, okay, because the PCAB is a weak base. I know it works as a PPI, but the PCAB itself is a weak base. Now the therapeutic use is it's a powerful acid suppressing agent, and it is given for everything. Okay, and it's working is kind of superior than PPIs, but although like overall PPIs are always administered, preferred. They are given for GERD and for duodenal ulcer, gastric ulcer, whatever. Anti-H. pylori agents are given because anti-H. pylori is a gram-negative bacteria or gram-negative bacilli, and it has to be eradicated. Okay, so the drugs are given with triple therapy and quadruple therapy. Okay, because this drug can cause rapid ulcers in the stomach. So the triple therapy is lansoprazole, that is a proton pump inhibitor, clarithromycin, that is a anti-H. pylori drug, and an amoxicillin. These are antimicrobial. Lansoprazole, the triple therapy is for 2 weeks, okay, like 14 days. Lansoprazole is given 30 milligram twice daily. Okay, clarithromycin 500 milligram twice daily, and amoxicillin 1 gram twice daily. The Okay, now quadruple therapy is again for 2 weeks. 4 drugs will be here. Omeprazole, okay, 20 milligram twice daily. CBS will be given. Colloidal bismuth. Colloidal bismuth what? Subcitrate. Okay, CBS, colloidal bismuth subcitrate, 120 milligram. Okay, 4 times daily. And tetracycline is given 500 milligram 4 times daily, and metronidazole, okay, 500 milligram 4 times daily. After completion of the above regimen, PPI should be continued for 6 more weeks to enhance the ulcer healing. So this is to kill the bacteria, okay. Now we'll study about drugs used in gastroesophageal reflux disease. For GERD particularly, we give PPIs. Okay, as I said, gastric is a disease where the contents of the stomach move back into the esophagus, and the gastric acid causes irritation of the esophageal mucosa. Okay, resulting in esophagitis and everything. PPIs and H2 receptor blockers are given. I already told you the mechanism, I'm not going to explain. PCABs are again preferred. Antacids are always preferred. Prokinetic drugs like domperidone are given. It increases the tone of lower esophageal sphincter, okay, and enhances gastric emptying. It does not affect the acid secretion. It's just prokinetic drug. It kind of increases the tone of lower esophageal sphincter. And sodium alginate is given. Okay, it is a very good drug. Even I have taken it myself. It forms a froth over the contents of the stomach, which helps to prevent the effects of gastroesophageal reflux. Whatever the content of the stomach is, it forms a froth. Okay, it's a very basic thing. So that was it, and we are done with this. We are done with peptic ulcer disease and GERD both. Let's go.